So I have, my duty this morning, or my goal, is to try to educate you regarding some of the results that we found from the multiple studies that have been done based on your data. And it's actually very interesting data to me, being a shoulder nerd, but it's very applicable to how we manage patients. So one of the things that I would like to share with you is that your efforts and your time are very meaningful, and we thank you for it. You have helped change our understanding of rotator cuff disease, and that's very true. And you're also having a direct influence on the way we manage future patients. So the time that you spend is meaningful not only to yourself to try to figure out, well, what's my tear doing with time, but you're really, whether you understand it or not, you're really changing how we counsel patients down the road. And I want to share with you exactly what I mean by that. So as Dr. Yamaguchi showed these slides earlier, this is the rotator cuff, and the business end of the rotator cuff is the tendon. So the tendon is what connects the muscle to the bone. And the majority of the problems that we see in the rotator cuff happen right here where this arrow is. And that's where the top tendon attaches to the bone. And if there's damage to the muscle tendon unit, it's almost always in this area. So this is where we've studied, this is the primary focus when you get your shoulder ultrasound on what's happening to the tendon in this region. And you hear terms like partial tears and full thickness tears. Having a full tear does not mean that all of these tendons are torn off the bone. It just means in that one area where the tendon is damaged, this one little area, that it's disconnected. It's not just frayed, it's disconnected in that one area. So when you use terms like full thickness tears, it scares patients sometimes. They might think that the entire rotator cuff tendon is torn, but you're talking about a very focal area of detachment many times. We do know that tears are very common. This is an intraoperative photograph of a rotator cuff tear, and this is kind of an extreme example of a large tear, but the tendon here should be firmly attached to the bone, okay? So you're looking at it through the camera, the socket's in the background, the ball is down here. This is what the tendon looks like before we repair it to the bone. There were some things that were known about rotator cuff disease prior to the initiation of these studies. Things such as age is the greatest risk factor for development of a tear. Many tears are painless. But the aim that we had with the NIH-based research is to describe what happens to these tears over time, as what Dr. Yamaguchi mentioned. And to this point, we've had about 8 peer-reviewed publications related to the natural history of rotator cuff disease, and we're soon to report our larger study examining the risk of tear enlargement and pain development over time. So this is our big 5-year follow-up data that will soon be out. What we've learned so far, again, this is a slide that Dr. Yamaguchi touched on earlier, is that the incidence of a tear is directly related to age. And that relationship is very strong. And the data that was out there prior to Dr. Yamaguchi's publication was actually fairly weak. This data is very strong, and it stood the test of time, to the point where if you have a patient in your clinic with pain in one shoulder and there is a tear in that shoulder, over the age of 66 years, they have a 50% chance of having a tear on the opposite side. So it's useful information when counseling patients. For years, it was thought that the bone spur in the shoulder was responsible for creating the rotator cuff tear. And what doctors mean by bone spur is the shape of the acromion bone, which covers the rotator cuff tendons. And these are the 3 types of bones of shapes to the acromion that have been described in the past. And what we found with one of our studies is that the shape of the acromion had little to nothing to do with the presence of a rotator cuff tear. It was only when you saw a large spur on the off of the bone did you see a greater risk of rotator cuff disease. So the majority of you all in subjects who have rotator cuff tears, the shape of the bone has very little, if anything, to do with the presence of a tear. It may have something to do with the amount of impingement pain that you have, but the spurs do not create the tear. And this was a fairly compelling evidence from the NIH study. One of the things that we discovered as well is that for shoulders that have a painless rotator cuff tear, the majority of patients have a normal shoulder, truly have a normal shoulder. You don't know that the tear is there. Their range of motion is good. If you measure the strength, there's very little drop off in the strength except when the tear gets larger with time. And if you look at our functional scores that we use to measure shoulder function that we publish research with, they're essentially normal. So that tells us that the majority of painless rotator cuff tears are what we call well compensated. So they have not reached a critical size where they begin to throw off the shoulder mechanics. And what that tells us is that the onset of pain is what heralds a problem. So, and I'm going to prove that to you in the next few slides with some of the data we're going to present. So, painless rotator cuff tears, as long as they're not huge, are very well tolerated. So some of the data that we looked at relates to the biomechanics of the shoulder. And you get x-rays every time you come in, and you might think, well, why do we have to repeat these year after year after year? One of the important things that we're looking for is what's happening to the ball in relation to the socket when you raise your arm, okay? And there's a phenomenon called proximal humeral migration, where if the rotator cuff tear reaches a certain size, the rotator cuff tendons can no longer center the ball very well in the socket while the deltoid muscle is firing. So we try to examine when does that happen. And what we found that for painless tears, migration of the ball really was uncommon, and it was only seen with the larger tears. And then in painful shoulders, there was a critical size about 15 millimeters in size. So you're talking about 2/3 of an inch. If the tear got larger than that, you started to see migration of the shoulder. And that's important because when you see migration of the shoulder, that predisposes you to accelerated patterns of arthritis. And it's also something that is generally thought to be something you can't reverse later with the surgery. So going in and repairing the rotator cuff later has not been shown to reverse the migration that happens as a consequence of that tear, okay? Some of the most interesting research that we've done is actually looked at the location of tears. So for years, it was felt that the tear in the rotator cuff happened in the tendon insertion right behind the biceps tendon. And that was the convention for 15, 20 years. And some very interesting research done here shows that the tears actually start a little bit further back in the rotator cuff, in the middle of what we call the crescent of tissue. And the tears actually begin here, and they seem to enlarge in both directions from that point. And that's kind of an interesting finding that kind of challenges the dogma or the traditional teaching on rotator cuff disease. So the majority of the tears that you have in your painless shoulder actually start back here, and actually less than 1/3 of the tears involve the front edge of the rotator cuff. When the tear does involve the front edge of the rotator cuff, you've got a problem, because we've shown in another study that when this front edge is disrupted, the tendon tends to pull off and migrate this way, and you're more likely to develop atrophy or muscle wasting in that rotator cuff tendon. So if the tear is located back here, the most common location, it's buffered. The tendon doesn't retract much, and the atrophy that develops in the tendon is much less likely to happen, or if it happens, it's going to happen slower. When the tear involves the front edge or the cable insertion, you're more likely to have muscle atrophy and probably develop a problem within the biceps tendon because of the location of the biceps tendon against the tendon edge. One of the more recent studies that we did is we analyzed shoulders with new pain at the 2-year report. And what we found is about 1/4 of the patients at 2 years started to develop some pain in their previously painless shoulder. And what we found, the risk factors for predicting the onset of pain were twofold. Number one is if your tear was slightly larger at the time we enrolled you in the study, there was a slightly greater risk for development of pain over time. And then if your tear was growing, So if we saw growth of the tear size on ultrasound, that was somewhat predictive of a risk factor for developing pain later. But what we found is that there were a lot of patients that developed pain that didn't have growth of their tear. So there were a lot of unanswered questions as what causes the onset of pain. And that has kind of prompted, has urged us to continue to follow your shoulders over time. And this is new data. This is data that no one else has seen. So you guys are privy to this much sooner than most. But our 5-year data seems to suggest that if you follow patients over time, there's a stepwise risk of tear enlargement. So we mentioned 23% of tears were enlarged at a 2-year time point, and that number increases to 49%. So half of the shoulders involved in this study showed enlargement over time. And if you looked at the risks were much greater if you had a worse tear to begin with. And by worse tear, meaning a full thickness tear versus a partial thickness tear versus a shoulder with no tear. So that was a very interesting finding, and it's actually fairly novel as well. So what about pain? 46% of the patients enrolled in this study developed new pain at some point during the study follow-up. And the risk for pain development is greater based on the tear severity. So if you have that full thickness tear versus just a frayed or partially torn tendon, there was a slightly higher risk for pain development. And one of the biggest findings of this study is we showed a very strong relationship between tear enlargement and the development of pain. And that was not seen to the same degree on the 2-year report. So we do think that there is a substantial increased risk for the pain development that comes at some point following either at the time of tear enlargement or at a later time point. Some interesting findings, and some of this flies against conventional teaching, is that the age of the patient didn't correlate with the risk of tear progression, okay? Smoking status did not correlate with the risk of tear progression, and neither did gender, okay? So it seems to be, there are some factors that we're starting to tease out, but age, smoking, and gender are not those. Interestingly, hand dominance is. So if you're asymptomatic or your painless tear is in your dominant shoulder, there is a slightly higher risk of tear enlargement over time. So activity level may have something to do with this. So to summarize some of our findings and some of the things that we mentioned to patients in terms of counseling, painless tears are indeed at risk for becoming painful and enlarging over time, and we're starting to understand those risks better because we can plot it out at yearly time points now. Please, you should not ignore new pain in a previously asymptomatic shoulder, because this could mean your tear is enlarging. Routine surveillance is important for painless tears, especially full thickness tears. And what we mean by that is surveillance means checking in on the patient periodically, even if your tear remains painless. Checking in ultrasound is important because tear progression happens, and sometimes it can happen without you knowing about it. It's not always painful. So how do we use this information when we're counseling patients? So how is this information directly applicable? We use the natural history information to try to direct treatment in patients and try to identify patients in which it's safe to watch for a while, and those patients that we feel like are at higher risk for developing problems later and who might actually develop a tear that's not repairable. So usually when you see a surgeon, you have a discussion about the risk and benefits of surgery, right? But you actually, given the progressive nature of rotator cuff disease, you should also have a discussion about the risk and benefits of not operating. So if you flip the coin, there's actually risk and benefits of not operating that might be greater than actually going in and fixing the problem. What are the risks with non-surgical treatment? Well, there's a risk of the tear growing. There's a risk of alteration in the normal shoulder mechanics. And there's a risk of progression of muscle wasting. And a lot of these changes, when they happen, even with successful surgery, you can't reverse them, okay? And then one of the big concerns is the ability to obtain healing with later surgery. So when you're deciding surgical versus non-surgical management, the rationale is basically understanding what are the risks of development of irreversible changes in the shoulder, and that's different from patient to patient. And that individual risk will dictate the urgency for surgery. And this basically it boils down to these risks are influenced by the age of the patient and the age of the tear, because the age of the tear determines the size of the tear and the degree of muscle wasting in many cases. So currently for people that were considering when do we operate early? I mean, who are the ideal candidates for early surgery? And we're talking about painful shoulders. We don't advocate operating on any of the shoulders that remain painless, okay? We advocate watching them closely but not operating. But who are the best candidates for surgery when the rotator cuff tear is painful? And it's ideally you have patients that are younger than the natural history is expected for a rotator cuff tear. So you're talking about patients under the age of 60. The ideal candidates are full thickness tears that are small and medium in size, because those tears are much less likely to have muscle changes, and those tears are less likely to have disrupted the normal mechanics of the ball within the socket. Tears involving the front edge of the supraspinatus. The supraspinatus is that top rotator cuff tendon. When the front edge is torn, there's a much higher risk of retraction and muscle atrophy over time. And then acute tears, regardless of size. Acute tear is a tear that comes on either from injury or sudden onset of pain with a loss in function. So in those tears, the tendon has not been detached long enough to start to develop the chronic changes that can affect the outcome of surgery. So these are the patients that we generally think are your ideal early surgery candidates, and a lot of these decisions have come from your all's data, from the data we obtained from the natural history study. We maximize conservative management for shoulders where some of those irreversible changes have happened. So you're talking about older patients or patients with larger chronic tears regardless of age. The other subjects or patients that we recommend maximizing non-surgical treatment on are those patients who have tears that are stable, so they're not growing and they're minimally symptomatic. So a lot of those patients will do better, or at least do well, with just observation, and that's where a lot of you all are right now. Okay? Thank you.